Welcome to Medicine for Good podcast. I'm so pleased to have one of my colleagues join me today, Phil Grant. Phil Grant is an assistant professor of medicine in the Division of Infectious Diseases at Stanford, and he is also the director of the Stanford HIV program. He has a research interest in both managing acute and chronic viral infections. Welcome, Phil, to the show, and thank you for joining me today.
Hi, Julieta. How are you?
Very well, thank you. So we'll just dive in, right? So Phil, it's interesting. Your interest in acute and chronic viral diseases. Could you just give us examples of acute diseases and chronic viral diseases?
Generally, I've done a fair amount of work over the years with HIV and hepatitis. So I started uh, being interested in medicine in 1993. I remember very clearly with certain kind of the media with HIV being very common, and then people I knew also having HIV. So I ended up going into HIV care. And so it took me a while, and then I got into doing some research in HIV. But I've also pivoted into other chronic viral infections like hepatitis C. I've done some things in Rwanda with both HIV and hepatitis C. And then I've also been doing some things with influenza. So when the coronavirus epidemic uh, started here in California, it's something that seemed to fit with what I was doing previously.
Oh, thank you for sharing that. So, we are right in the midst of the pandemic, and I know it really had been a unprecedented pandemic that really changed every facet in our lives. So, take us back, if you could still remember the early HIV era and the pandemic and the fear generated by that, and compare it and juxtapose that experience to now with the pandemic.
Yeah, I think there's lots of similarities. Some of the stigma associated with having HIV is something that I think people are feeling a little bit with having a coronavirus, especially early on, when people of color were primarily affected with coronavirus. It also wasn't that different from sexual minorities being affected with HIV early. Um, in terms of the overall fear in society, uh, there this predated a little bit my involvement in HIV in terms of the 80s. People weren't really clear how HIV was being transmitted, and so people in. But I've even seen this in my own patients. One of my lovely older women who got HIV through injection drug use. She wants to help take out care of her grandchildren, but her the parents of her son and then her daughter-in-law doesn't want her to take care of her grandkid because of fear of transmitting HIV. When in fact, as long as she ever has blood, she can wear gloves. But there's a lot of the same fear. Some of my patients who had coronavirus, months later when they're no longer infectious, people are still don't want to stay near them. They tell them, stay away from me, even if they're wearing a mask. So I think there's a lot of same types of issues, a lot of fear and uncertainty around how to catch it, how to prevent it, kind of thinking that the people who have it are somehow less than other people.
Yeah, understandably. I mean, even for me, as a medical professional, here at home, people are avoiding me. My neighbors are avoiding me. And I had one of my neighbors said, "Oh, don't visit Julieta because she is probably infected or she's always exposed." So it's really hard. We're discriminated against. And I know in other countries, like for example, in the Philippines, the healthcare workers are discriminated against in terms of their home, like apartment living and stuff like that. Uh, uh, they're being driven out of their apartment, so there's still a lot of fear about that. And I recall I was an intern when HIV was just beginning, and that's how ancient I am. Um, And there was a lot of fear among us, our house staff, because we will walk into the room with, like, we had this outfit like we will go to the moon. um, and one of our co-interns got stuck with the needle, and we were just so devastated. We didn't know what to do. We were so fearful that she's gonna die. So that fear and the fear now with COVID-19, you're right, there's some parallel. So just to dispel uh, myths about COVID-19, and to further be able to coexist with this virus, because treatment is nowhere in sight yet. Uh, Take us to the basic biology of COVID-19, its transmission, so we will better understand how to protect ourselves, and then outline the science of the transmission, and what is the science behind masking, social distancing, and hand washing. A lot of questions.
Right. So it's a pretty straightforward respiratory disease. It's secreted through respiratory secretions. So it's mainly in a droplet form. So that's relatively big. So that's where we feel like within 6 feet, if you're further away from someone that you're unlikely to get the infection. So that's the idea of spatial distancing, is if you're not with someone for that distance. It's been shown that in some rare cases, it can be more what we call aerosolized, being in much smaller particles like tuberculosis. So then it could spread across a larger distance. But for the vast majority, especially on the outdoor environment, it's spread by droplets. So if you're outside of 6 feet, you're going to be safe. Indoors, if you're in a conference or in a big family gathering indoors with not good ventilation, it could spread further. But for the most part, it's a droplet. The masking is also very straightforward. It's hard to understand why it got to people feel very uncomfortable. Just imagine you're sneezing and you have a mask on, your droplets aren't going to go as far as if you didn't have a mask on. And similarly, if you had a mask on, you wouldn't be inhaling other people's droplets as easily. So I think the masking, whether it's cloth, a well made, we emphasize having more than one layer cloth mask, but a well made cloth mask works well. There was just a lot of confusion when there was a shortage of surgical grade masks early in the infection. We weren't encouraging in the United States people to use masks, but now it's that people have access to cloth masks. It's really encouraged for people to wear that when they, for the most part, most of the time. For me, when I walk to the park, it's a very quiet walk, and I don't need a mask. I have one with me, but I don't always wear it. When I walk downtown, I always have a mask on because it's going to be more crowded. So I think it shouldn't be so complicated. It's hard if you're working outside in a hot day to keep a mask on all day. But I think for the most part, that's the story with the masks. They're all, in terms of like most infections, there's an amount of virus one needs to be exposed to get infected. So that's where the statement of, you have to be in close contact for 10 minutes talking to someone. So the shorter the interaction, the better. There are cases, it's not a black and white thing, so you could get infected with a much shorter interaction. But the times that people generally, most of the infections are occurring in people's workplaces, where they're spending a lot of time, or people's households. Less commonly just the supermarket and things like that, but it can also happen in those settings as well. I guess I should answer too around healthcare settings. Now that we have earlier in the epidemic, there wasn't a lot of personal protective equipment, but now that there is within the hospital, we're not seeing that much transmission among hospital workers. So that's good.
Yeah. Well, we're talking about the the amount or size of the inoculum, which is like how much you get upon exposure. Could you kind of like help us understand asymptomatic people being able to transmit the virus, and why is that why we also have to have mask on, even confronting other people who are asymptomatic?
That's right. Yeah. So I think this has been a lot harder to control than the previous SARS pandemics with SARS-CoV-1, which was several years ago, as well as another coronavirus, MERS-CoV. Both those people generally were infectious only when they're symptomatic. So it's much easier to control it because you can localize who's infectious, do good contact tracing among those people. Interestingly, this virus, you're most symptomatic, or you're sharing the most virus even before you're symptomatic. So maybe a half a day before you're symptomatic, that's when you have the highest viral load, and you can shed virus, even up to a week before you actually have symptoms. Even there are some people who are asymptomatic, never develop symptoms, that are also shedding virus. So people make a distinction between pre-symptomatic, meaning you are later going to develop symptoms, but at the time you think you're asymptomatic, obviously, because you don't have symptoms, or the idea asymptomatic, meaning you never will become symptomatic. So both people who are pre-symptomatic, meaning they are going to get some symptoms later on, maybe as soon as a day or two later, or people who are asymptomatic can both be highly infectious. So I think similarly to the idea is when you're in your common environment, if you're in an area where there's a fair amount of spread, you really have to consider almost anyone to potentially have infection. So even if they're your lovely mother, your grandmother, or your best friend, and they look very well, you should also still take precautions as much as you can.
So that is the value of the mask, no matter what, right? So, and the more you
Yeah,
are in an enclosed space, the worse it is. And it's better to be outdoor. Of course, with the smoke that we recently faced in California, being outdoor also was devastating for that, like 2 to 3 weeks time that we were here in California. So now we would leave the science behind all of those rituals that we're doing that we should promote. What could you tell us about a treatment now? Is it really treatment? Is there a treatment? And what are those?
yeah,
And what is the data behind
yeah. So
that?
I think we made yeah. So I think we made the analogy earlier around HIV. Just in terms of probably the most recent large pandemic that the world has faced. In my mind, was HIV, and that came. The first cases were described in 1981, although there were cases that were present but not understood even before that. But really, 81 is when it hit the world, and for years there was no treatment. It wasn't until 1987 that AZT became available, and then even AZT and the other early medications really didn't change the course of the disease dramatically. They helped a little bit; they extended people's lives, but they weren't game changers. It wasn't until 8 years later, 1995, that there was combination therapy, or people call it HART or ART, depending where you are. So it took 14 years from the early description of the disease to have effective therapy. And now, as people know, people live, very healthy lives, and they're actually don't transmit to other people when they're effectively on antiretroviral therapy. So if you think about that from now, we're right now the first descriptions of coronavirus really around this. The first cases were in December 2019. That's why we're calling it COVID-19 as opposed to COVID-20. But really, we didn't see much of it until 2020, and China started to put out information on it middle of January. So we're only 10 months, really. I guess 9 months into the pandemic right now. Right now we have medications that you might think a little bit are like AZT, like remdesivir is an antiviral. It's a polymerase inhibitor. It definitely shortens the time one is ill. There have been several studies that have looked at whether it reduces mortality, and it doesn't appear to reduce mortality, but it does reduce the time someone's come in the hospital by approximately 4 days. So it's not a game changer, but it does improve people's overall condition. For more ill patients, just like with a lot of other conditions, steroids can reduce death, because you have not only the virus is impact on the body, you also have the inflammation of the body that can cause problems in the lungs. So the dexamethasone people have seen have reduced mortality. So those are really our bread and butter medications that are being used. There's other things that are been studied that are still in the process, or some things that are probably not effective that have been studied as well.
So give us a bird's eye view of monoclonal antibody and, other antibody treatment out there.
Yeah, so the idea would be the same. Several different companies have produced antibodies to the outside of the virus. So they call it call it coronavirus because it looks like a crown. There's the spikes, and those spikes basically attach to a part of a cell within the lung, and then basically causes that to go into the lung tissue and then cause lung damage. So different companies have produced antibodies to those spikes that hopefully will prevent it from going into the cell and causing lung damage. The two companies are Eli Lilly and another company called Regeneron. Regeneron has done antibodies for Ebola, and was shown to be effective for Ebola. That's the same one the president received a couple of weeks ago when he was ill. Even though it's not been approved, it's still in clinical studies. So I think we won't see definitive results on either the Eli Lilly drug or the Regeneron medication for several months. The Eli Lilly drug is on hold. The study is on pause right now. The active one study, as it's called, through the NIH, and it's paused right now. They're just making sure it looks safe from one adverse event that was reported. But I think they're both promising. And, but you don't know what's going to work until you see. In HIV, there were so many false starts about medications people thought were going to work, but didn't, or had too many side effects. So I think people have lots of hopes for things, but people have to remember we've only been in this epidemic or pandemic only 10 months, and it's going to take a while to really get out of it from a medical standpoint. And until we do that, public health is going to be by far the most important thing.
So, but is it accurate to say that the antibodies will work early in the disease, will work better early in the disease before further viral replication?
I think that's what people think. We will see if that's true. The reason we will think that is because it takes a while for the body to develop antibodies. And some early studies with the antibodies have shown people have a better response if they have a negative antibody in their own body. So early on, your body is working really hard to produce antibodies, and then the virus is really more or less replicating unchecked. So giving an artificial outside antibody can prevent that replication. That's the theory. And so we'll see. So both the studies are looking at people who are early in disease, not this late inflammatory disease, but kind of the early stage, which is probably more caused by just the virus replicating.
Okay, that's good to know. Now, take us now to this hype of acceleration of viral, the vaccine against this virus. Describe to us the efficacy.
It's so much in the news. So I remember going to a conference, this was in 1997, when I was a medical student, on HIV vaccines. And people were saying it was right around the corner. And actually in 1984, the Department of Human Health Service person in the United States says we should have a vaccine for HIV within a couple of years. So I think the predictions, obviously we don't have an effective vaccine for HIV, and it's been, how many years? Almost 30 years now, almost 40 years now, actually. I'd say this disease is easier to develop a vaccine for than a chronic infection, because a body is able to control it itself. We're just trying to trick the body to produce an antibody to just basically a part of the virus. So it should be possible to have the body produce antibodies to spike protein. There has to be a lot of studies done to show the vaccine is safe. We probably can get the body to produce spike protein by various different methods. Antibodies to spike protein. We have to have a vaccine that's very safe. If you're going to give this vaccine to billions of people around the world, we have to have a very low rate of side effects. So several of the studies that have started actually have paused to make sure that any of the side effects that have occurred are not related to the medication, and if they are not serious. So I think it's a lot of time. People want things to happen very fast, but it may take. I would expect that. You won't be able to go into your local pharmacy to get a vaccine until some point in 2021, and maybe it won't be until summer of 2021 that it'll be mass produced enough that the average person can go to their pharmacy and or their doctor's office and get a vaccine that works and we know is safe.
So, so it's not just the efficacy of the vaccine, but safety, and that's what's like holding the progression of this, right? So it has to be really safe to a massive number of people.
Yeah, I also want to give you an example of like the polio vaccine, which is probably one of the greatest health successes in the United States in the 50s. And that at that point, polio was also a major health concern. Children were getting paralyzed and dying at that point. Salk was the person who was the first one to develop the oral polio vaccine. And the studies from the time they started to the time they ended was over a year. So it's going to take a little bit of time to get the data, and then it turned out to be quite effective. But you really have to I think we all have to be very confident that the vaccine's safe as well as effective, and there's really no way to rush that. You can go fast, but you can't rush. So I think that's the even though there's a big for some reason, a lot of this political stuff has entered into health, which is a bit unique in our, my professional life that there's been such a political statement on. I think it's almost like, one team is rooting for and against this virus, or I don't know how to put it, but as opposed to everyone being focused on controlling the virus as well as keeping the economy rolling as best as possible.
Yeah, that is very interesting that everything from mask to vaccine are so politicized, And so, talking about that, how would you think that as medical professionals and scientists, how could we help the public restore, or the public or the leaders restore their trust and respect for science and sound data?
Yeah, I think it's hard. I mean, we're living in a conspiracy theory world. There's just so much misinformation, not just on health things, but on other things. And so I think a lot of people don't have the education necessarily separate like myth from fact, given how much information is out there on the internet and things people hear. But I think it's a pretty straightforward disease. That's why it's so confusing to me. Maybe 2 out of 100 people who get this will die. Many people won't be so sick, and it spreads from person to person, and using a mask can protect you as well as staying socially distanced. I don't think anyone's saying that we want to shut down businesses or schools. I think we all want people to get back to. My daughter just started her school this Monday. I think we're all very happy, but they have a lot of precautions to keep the kids safe, as well as the parents and the grandparents of the kids safe as well when they come home. So I think, to me, I think just turning down the volume maybe, as well as I think we do have a pretty uniform message in terms of the medical world. There are, of course, people have arguments around what the balance of health policy versus, whether certain things should be closed or not, whether fans should be allowed in the sports stadiums, and if so, how many. Those are all questions that are probably not things that doctors necessarily have any expertise. We can tell you how it's transmitted, and I think people have to make the decisions about how to do the things we need to do as a society most safely.
Okay, so final message for our listeners, Phil.
I think the final message is to try to live your life as fully as possible. in a difficult time. So have your friends over for dinner, but have them outside and have at a park, maybe set up 2 blankets that are a certain distance apart, or if you have a backyard, you could set 2 tables at a certain distance. I think have your kids see their friends, but have them see their friends with masks. Make sure, I think those are 2 kind of things that I would emphasize is I don't think medical science, I don't think it's as complicated as people say. We're not saying don't live your life. We're just saying live your life as fully as possible with the given rules that we have, knowing that there are risks to being in a closed place with lots of people. And also sign up for volunteer for vaccine studies, because we all will need as many volunteers. And there's lots of safety rules within these vaccine studies to protect the participant. So we're running one here at Stanford, and so I'm hoping that people. I guess thirdly, so I'll say 1 is live your life fully. Secondly, follow the rules; they're there for a reason. Thirdly, I'd say sign up for the vaccine studies to support them. And fourthly, be patient. We are going to get through this. We've only been, even though it seems like a very long time, it's been about half a year. And 6 more months, if we're all patient, we'll be in a lot better place.
There you go. Thank you so much, Phil, for your messages and really translating this, what we call a science, to a practical solution to live our lives day to day. So thank you so much. There you go. Mask, mask,
Thank you,
mask.
Julieta.
Bye.
All right. Okay, bye, Julieta.
Bye bye.